Hey, everybody. This is Dr. Jeff Jaguar, who is I'm the host for our monthly Cancer Prevention and Wellness that's sponsored by the Cancer Survivors Park Alliance. Every month, we try to introduce a topic related to cancer, be it a specific cancer, cancer's etiology, its treatments, the latest screening recommendations, and most importantly, prevention measures. Sometimes those can be clear cut, but often prevention is related to lifestyle choices and lifestyle changes. So we talk a lot in this series about diet, and we talk about exercise and mind-body techniques, sleep hygiene, social contacts, and we go over it all. And if you go to our website, cancersurvivorspark.org, under programs, there's a whole library of the talks that we've done over the last 3 or 4 years. Today, we're going to talk about viral etiologies for cancer. And to help us with that, we have Dr. William Wooten, who is a specialist at Prisma in the Midlands in Columbia and Sumter. Dr. Wooten was originally from South Carolina, but moved to Virginia, came back for his university training. His undergrad was at South Carolina State University, where he graduated summa cum laude. He did a master's in transitional and clinical research at Clemson, and then he went to Ohio University Heritage College of Osteopathic Medicine. And since he left medical school, he has been training and specializing, and I'm going to let him take you on that journey. But Dr. Wooten, I appreciate all the work you put into this presentation, and welcome to our broadcast.
All right, Doctor. Thank you, Dr. Jaguar and the Cancer Survivors Park Alliance, for this opportunity to speak, regarding viruses and how some of the viruses are linked to certain cancers, and I'll say something about our training. So, actually, recently, I did the kind of like a master's equivalence certificate with Clemson. That was actually very recently. I actually
Oh,
finished
wow.
that.
Okay.
But yeah, that's actually a program sponsored by Prisma Health, and so
Okay.
I was pretty much kind of voluntold to take it, but I'm glad I took it.
Yeah,
The
good.
chief of the division came to me a couple of years ago and asked if I wanted to take this. It's like a clinical and translational research certificate class through Clemson, and Prisma Health sponsors it, and so I took advantage of it, and it was very helpful. So yeah, it was confusing. That's actually what I recently did, but yeah. So my training, and internal medicine, Mount Carmel Health System in Columbus, Ohio, and then I did a combined fellowship in infectious diseases and critical care medicine at East Carolina University. I've been with Prisma Health for a little over 3 years now. I
Yeah.
practice at the Sumter and Columbus campuses, or Columbia campuses, sorry. And I also work with our fellowship. We do have infectious disease critical care fellowship, and so I work with the fellows as well. So
Well,
once again,
critical care doctors are real doctors.
thank
They
you.
take care of real sick people, and
Yeah.
often they have a lot of infectious diseases. So you're the perfect combination.
Well, thank you. And, just to add one more thing is that, yeah, so when I was going through fellowship, it was right in the heart of COVID. So,
Yeah. Oh,
uh,
man.
yeah, so, it was definitely a tough time, but did learn a lot. And, I think we do have some success stories, wish we had more. So,
Yeah.
but go ahead and get started with this topic today. And so when you see oncoviruses, basically these are viruses that cause cancer. All right, HIV, everybody's heard of that. Human herpes virus 8, which is called HHV8, and that really comes from HIV in a lot of situations. Hepatitis B, hepatitis C, so a lot of people have heard of those too. Human papilloma virus, HPV. So you've probably seen the commercials regarding the vaccines for that virus as of late. Epstein-Barr virus. If you've heard of infectious mononucleosis or mono, right? Particularly for our teenagers and young adults. That's what that is. And then, yeah, I want to mention it because this virus can cause cancer. It's less known, but if you've had any experience or any time in your life living in the Caribbean or in the islands, then human T lymphotropic virus or HTLV1. So just to start out, to provide some basics. And so, like I said, the premise of this talk is how do viruses cause cancer? Well, if you think about cancer in the simplest way, is that cancer is a dysregulated growth of immature cells. All right, now how does that happen? So when cells are made, it goes through a cycle. All right. And so to break it down very simply, you have four phases. The first phase, G1, is the cells preparing to divide. And then the S phase is where it makes its own DNA copies. And then G2 phase is when it condenses all those DNA copies. And then M is mitosis is the basic last phase where it's going through the preparation to divide. All right, kind of going back to G1. But anyway, when these cells are made, and you have one, then you have two, and then it just keep multiplying and multiplying, and then it just keeps repeating itself. So in a nutshell, that's what the cell cycle is. Now, how do viruses interact with these cells? All right. So, on the left side of the screen, this is basically you actually have two, structures of viruses. And so you have some viruses come with like this envelope, all right, here. And this is more of a, say, like hexagon. And then some viruses come with more of a circular outer covering or outer membrane. All right. And then inside, the cell or inside the virus, you have the genome, which is this genetic material. All right, and so how do these viruses interact with these cells? So first is attachment. So you have these attachment proteins. And once it attaches, it penetrates through the cell. And then once it penetrates through the cell, it disassembles. So basically, what allows this genetic content to be pretty much replicate inside the cell to incorporate within the actual genome of the actual cell that's invading. And then once it's done doing all its work, then it kills the cell. Now, you're wondering how these two relate, right? So, there's the basics of viral oncology. So how do viruses cause cancer? As I said, it's a dysregulated production of immature cells. And what happens is these viruses, once they invade these cells, it causes a disruption of cell signaling pathways, right? And so, really and truly, and like again to the last point, is the inhibition of cell killing, all right? And so each of these cells and the way that our body is designed is that, not all your cells are good. And eventually, after a while, your cells will age. And so we basically has to have a process called apoptosis or cell killing, right? But what happens is that our cells have something called tumor suppressor genes. All right. And so these are genes that obviously help suppress tumors or cancer. Now, what some of these viruses do is that it turns off that signal to suppress these tumors. And so when that signal's turned off, then tumors, have a higher chance of developing, and hence you have cancer. And then how does the virus interact with the host, right? And so I love pictures. It's kind of comprehensive, the picture to the right. But first you have some entry into the host, right? So viruses usually are acquired typically when we're younger, all right? And it's either like through the skin or through, maybe some contact with blood or any other type of fluid, all right? And then once it gets into the body, it usually gets in through surface, so either skin or mucous membrane, typically your mouth or your respiratory tract, your lungs or your GI tract, your stomach. Okay. It undergoes primary replication. So once it gets to those sites, it divides and then it spreads throughout the blood. And then once it spreads throughout the blood, it attacks certain tissues and cells. And so what happens is certain viruses have a certain affinity for certain cells, tissues, and organs. All right. Once it gets to those areas, then it undergoes further replication. All right. I mean, it's going to go ahead and multiply some more. And then after that, it causes cell injury or latency. Now, latency is where it finds a home there. All right. And so, and most viruses are latent. And when you have a actual viral infection, it's usually a latent reactivation. So a good example of this is zoster or shingles, is what you know. So pretty much everybody's going to be at risk for shingles. If you had chickenpox when you were a little kid, then you're going to be at risk for shingles. And what happens is that after you're infected with the chickenpox, it actually is latent in your nervous system, all right, in your nerves. And what happens is that in any moments of stress, and stress could be really anything, it could just be the fact of getting older, did you have Another, did you have a cold? All right. Were you exposed to hot weather, whatever? It could be any type of stress, right? Nothing in particular, then that virus can reactivate. All right. So shingles is probably the best example for this. And then the last part is the host immune response. And so everybody's immune response is going to be different. Okay. And so this is dependent on if you have any underlying health conditions. All right, if you are immunocompromised, when we say that is, for example, if you have a cancer, all right, if you have generalized cancer and you're undergoing chemotherapy, then your immune system is going to be weak, and therefore you're at risk for reactivation of some of these viruses in addition to other illnesses.
Now, William, Dr.
Yep.
Wooten, this is nothing to do with the oncovirus, but as you bring up chickenpox, is there a vaccine for that now?
Yes. So it's a good thing. And so I actually have a personal story with this, and I love sharing this story. So once again, I'll show my age here. So
Well,
the
you're
the
talking
the
to somebody that
vaccine.
just had chickenpox, not, when I was younger, and that's how I got
Mhm.
my immunity.
And so here's the thing: I got chickenpox naturally. I was probably one of the probably in my generation, probably like one of the few that actually get naturally because I remember my parents actually had me set up to get the vaccine, and so I was in the fourth grade, and I was sitting in the aisle, and three other people in my aisle already got it, and so I remember I was supposed to go the next day. My parents had me set up with a pediatrician, go get the vaccine. So this, I said fourth grade, so it's like 97. All right, and I remember I came out the shower and I had all these red dots all over my body. And I knew at that time,
Too
I was
late.
very smart. And so I knew I had it. So I told, I mean, I think I had pretty good knowledge of, vaccines, immunology at the time. I told him, like, well, I guess I don't need to get a vaccine now
Right,
and to cancel
right.
appointment. And so, yes, there's been a vaccine out. And I remember since, like I said, 97. And so, um, you know, and I'm trying to think. I have a daughter who's 21 months, and so I'm trying to remember if she's gotten her first
So
dose
does
yet.
that mean
But
that
it's
people who got the vaccine are not going to be at risk for shingles?
so here's the thing: you can still be at risk for
Okay,
shingles. All right, and so it's to educate the crowd. So the whole purpose of vaccines is not necessarily to. I mean, it depends which virus it is, but you know, the vaccine doesn't necessarily, and most of the time it does prevent you from developing a serious illness. I'll put it like that. All
right.
right. Because not just because you get a vaccine does not always mean that you're going to, not acquire the actual virus. All
Okay,
right. So yes, yeah, to your question, you're still at risk for getting shingles.
okay.
All right.
That comes up. So,
Yeah.
yeah.
And so you're still, yeah, for sure. Now, I will say that getting the vaccine, the chickenpox vaccine, which obviously now probably most people, like I say, like my age are probably older, probably already got naturally. Those who are, I'll say, probably 10 years younger than me, they probably had got the vaccine.
Right.
And so, but it's not like if you're older, you need to go get chickenpox vaccine. Like, don't
No, no,
don't
no,
do that.
don't do that. Yeah,
Yeah.
right.
So, all right.
I'm
So
sorry, that
yes.
was just an interesting aside just for me, but
Yeah.
somebody might have gotten some benefit from it as well.
Oh, so yeah, for sure. All right, so first we'll talk about human immunodeficiency virus, HIV. I'm sure everybody's heard about this. I think some of the maybe at least in probably according to me, maybe the most well-known person I said or celebrity I had is probably Magic Johnson. All right. And so, but we've come a long way since then. This virus is actually detected, let's say probably early 80s. All right. And, unfortunately, a lot of the treatments at the very beginning, I'm gonna say they didn't really work that well, but had a lot of, I think, serious side effects. All right, and so, and it was also seen more of as a death sentence. But I think we've come such a long way from that time, and so now it's definitely not like that at all. But I think everybody knows it's mostly sexually transmitted. Um, and just have to bring this up, but you know, yes, it's all over the world, but it's different in certain regions. So, say if you go to like Africa and in the Caribbean and Asia, it's mostly heterosexual intercourse. But usually in the US, it's usually male, that's what MSM stands for, male sexual male. Now you can still have some you can still get it through heterosexual contact. Most of the time, it's usually men sex with men, but you can also get it through injection drug use. Now, this is more so outside of the US.
Okay.
All right. At least in my experience, I haven't come across a patient that got it through injection drug use. All right. Now I'm sure and it could probably increase your risk, but mostly here in America, it's usually men sex with men, usually, or MSM. That's what we call it. So by the end of 2016, the estimated number of people with HIV worldwide was probably almost 37 million, from a cumulative total about 76 million infected since the beginning of the epidemic. And like I said, it was since like the 80s. All right, and that has to do with more access to treatment and more effective treatment. And so we call this HAART, or highly active antiretroviral therapy. And I wanted to mention this part here about the Ryan White HIV/AIDS program. So this is a federally funded program. This is the largest federally funded program. And so I tell patients all the time, because there's a lot of social stigma with this. Luckily, not as much as there used to be. But I tell patients that you don't have to have, any money in your bank account. Even if you have one, you don't even have to have a bank account. You don't have to have any clothes, a car, nothing. You can literally walk in the clinic as you are and you will receive care. And so that's a great part about this. And so I provided the link there, but Ryan White was a teenager. He was actually from Indiana, right? And he was a hemophiliac. And so he actually acquired HIV through like a blood transfusion. And when he was diagnosed with HIV, he was not allowed to go back to school. And unfortunately, he died at 19 in like 1990. So because of that, there was a law that was signed for this program, right around the time like 1990 or kind of early 90s for this. All right. And then the last part here is pre-exposure prophylaxis, or PrEP. So I'm probably seen the commercials for it. And so PrEP is for those who are at high risk for HIV. Now, these aren't for people who already have HIV, because um, you actually need to be treated for that. PrEP contains 2 of the 3 medications for HIV. All right. Most regimens contain at least 3 medications. For PrEP, it's 2. And so, for this, patients usually have to be tested every 3 months. You're also tested for STDs as well, because, just because you're receiving treatment for HIV does not necessarily make you devoid of risk for getting STDs. So you have to watch out for that too. All right. So I'm gonna go through this really quickly, right? Because this looks like a lot, but this explains how it works, right? And so HIV infects one of your white blood cells called the CD4 cell. All right. And it's one of the cells that's important in pretty much helping your immune system function. So the thing is that how people die from HIV is typically due to some type of infection due to a weak immune system. So if you had a normal immune system, you wouldn't get some of these infections. All right. And how does it do this? It infects these white blood cells called CD4 cells, which help you fight infection. So, and, just kind of summarize all this is that here's your CD4 cell, and then, or this is actually a virus, and then it gets into the CD4 cell. And so these are all the steps that happen. And so typically, just to break it down, it attaches to the cell, it gets internalized, all the contents from the virus incorporate within the cell's genome, and then you make more of the virus that gets released from the cell, and then it just keeps going on and affects other cells. Now, the medication that we have, we have medications that basically intercept or I guess block these steps in the process of new virus forming. Okay, so this is what you need to know. We have a lot of your medications hit the reverse transcription, which basically is an enzyme that prevents the conversion from RNA to DNA. So, try to explain as simply as possible. So when you make new cells, you have DNA, RNA, and protein. All right. Now, what makes HIV very unique is that it is actually RNA that goes to DNA, RNA, and protein. And so, and this is where this reverse transcription comes in. So you think of RNA going to DNA. All right. And really all this is a bunch of enzymes that help, package up new viruses and then keeps infecting other cells. So we have medications that attack each of these steps. Best way to explain it. All right. So how does HIV cause immune dysfunction? Kind of what I talked about. It affects your CD4 T cells, which is a very important component of your immune system. All right, and it establishes persistent infection and then evades host immune responses, which allows it to keep replicating and infecting your CD4 cells. Now, because HIV weakens the immune system, you're at a higher risk for these opportunistic infections. So when we say opportunistic, these are infections that only come about when you have a weakened immune system. So if you have a normal immune system, you usually don't have certain, these certain infections. So for HIV, the most common infection that usually when people acquire that leads to a diagnosis is a type of pneumonia called PJP. All right. However, people with normal immune systems don't acquire PJP. All right. And then when you have a weakened immune system, it allows for you're at high risk for reactivation of these other viruses. So herpes zoster, which is shingles, is pretty much what we just talked about. All right. Now, how does HIV and really how most of these viruses cause cancer? They're heavily concentrated in the lymphoid tissue, so or the lymph nodes. All right. And this would call lymphoma. All right, and so two most common cancers or lymphomas is diffuse large B cell lymphoma, and that's pretty much lymphoma typically in your abdomen. All right, but it can be pretty much all throughout your body, and then your central nervous system lymphoma, CNS. This is basically lymphoma in your brain. And then what's the treatment? Well, you treat the underlying cause by treating HIV, which is your own antiretroviral therapy. Now, sometimes patients require chemotherapy as well. Now, moving on to humans herpes virus 8 or HHV8. Now, this really comes from HIV. So the cases my practice I've seen with HHV8 usually comes from HIV. All right. And we call this a Kaposi sarcoma. All right. And it's a endothelial cell cancer, which is basically a skin cancer. Now, that being said, this cancer can spread throughout your entire body, but this usually starts out as a skin cancer described by a Hungarian dermatologist back in 1872, this guy Moritz Kaposi, and then it was actually reported by another gentleman, Alvin Friedman Kine, in 1981. Now, what happened in 1981? Emergence of HIV. So you notice that this is really how HIV got detected, is because they're seeing a lot of men with these type lesions, and you're like, well, why is the case? And then you figured out they had HIV. So, and then another cancer that comes from this is we call it primary fusion lymphoma, and basically that's where you have fluid outside of your lungs. All right, so it's combination with a lymphoma with fluid outside of your lungs. All right. And then the treatment depends on severity of disease. If you're on any immunosuppression, now this is mainly if you underwent like a organ transplant and you're on medications to prevent rejection of the transplant. Now for HIV, it's a lot of times you have to be on treatment for the HIV. And then also, just depends on the extent of the disease. So if it's local, just skin, you could do chemotherapy, sometimes injection chemotherapy, or laser, and some of these other more local measures. Now, if it's spread throughout the body, usually you need basically traditional chemotherapy. All right, so next we'll get to hepatitis B. And so hepatitis B affects more than 200 million people worldwide. It's usually exposure to body fluids, typically blood, um, usually sexual type fluids, but it's not found in urine, sweat, or stools. Those are at risk, injection drug use, sexual contact with infected fluids, as I mentioned, healthcare and custodial workers, which is why if you are working in any segment in the healthcare field, is required that you have had hepatitis B vaccination. All right, hemodialysis patients, another one. Those born in endemic regions and their children. So endemic regions that have a high prevalence of hepatitis B, which is typically, your Southeast Asia area. All right. Hepatitis B is the leading cause of chronic hepatitis, cirrhosis, and hepatocellular carcinoma. So that's your cancer piece here. All right. Accounts for more than 800 deaths annually. Now, most people who contract hepatitis B, more than 95% mount a successful immune response that results in recovery. So usually, for those that have been exposed to it, your body takes care of it. and then you don't really have to worry about it anymore, right? And it's because you produce these antibodies against it, right? So your immune system work or function how it's supposed to be, right? However, reactivation can occur if you have some DNA that are present in those liver cells, right? And so I would say with this, since it's like prevention wellness, now I think a lot of people have had their hepatitis B vaccine, particularly when they were kids. Now, this is the other kicker to it is that you need to check your titers, particularly as you get older, because just because you got the vaccine doesn't mean that those titers will always stay at appropriate levels. So some patients do need to be revaccinated. If, just say they get older and that immune, maybe if their immunity declines, then you may need to be, revaccinated. And so you can have your primary care physician retest your titers if necessary. All right. And so
Would
this is
that
just a
come
break.
up if they had some abnormal liver function test?
Yeah. So, oh, and that could be one. Now, kind of my next one, which I'm really gonna get into, is hepatitis C. Now, that's really more prevalent, and particularly with individuals born between 1945 and 1965. Which now CDC has made it as a recommendation that all individuals born between that time period should be universally tested. Right. And like you said, it can be if someone just has mildly elevated liver enzymes. It's usually not going to be too elevated, but that could be a signal that, yeah, you might need to test for that. And I'll get into hepatitis C. Now, hepatitis B can be the similar, um, but we don't, at least in my practice, we don't really see that as much. Now, usually when, matter of fact, I just had a patient the other day, is that those who are undergoing any type of like chemotherapy, or receiving a medication that can suppress the immune system. One medication is called rituximab. If they're receiving that, say, for any type of autoimmune disease, then that's when we can see reactivation of this. Some and each immunosuppressive medication, that is not doesn't really carry the same risk for reactivation. So some carry a higher risk, some don't really carry as much of a risk at all. So in this graph or this chart here, this just shows how how the virus pretty much invades your liver cells and so on and so forth. Now, the difference between hepatitis B and HIV is that this follows the traditional pathway from DNA, RNA to proteins. The proteins get cleaved into um, different, to more viruses, and then it gets released from the cell. So that's that. And then here, this shows the prevalence of hepatitis B. There's more of a prevalence if you get in certain areas of Africa and then the Southeast Asia region. I would say here in America, prevalence is relatively low. And then here's a graph here that shows pretty much since 1982, it's just declined, declined, declined. And I mean, as late as this chart so was 2006, but a lot of this has to do with vaccination. And then this is another chart here, which I don't really go through too much, but on the left, it's when if you were to develop like an acute hepatitis, all right, and so you were infected some way, somehow. A lot of times when people are infected, it's, maybe it's a needle. Can't happen with IV drug abusers. That typically happens with hepatitis C, that at least I've seen. But your response is, this is like within the first, I think couple weeks, and you have your antigen, which is the virus, and then your antibodies start forming. And then on the right is more of a chronic picture. Now, why is this important? And I'm going to explain it in this table here. All right. And this is probably a lot to digest, but I just wanted to show this that, for, the audience here is that this is how physicians like me basically determine if you need long-term treatment for hepatitis B or not. And so, there's really kind of four different presentations. You have your acute hepatitis B, which a lot of times in those situations, patients don't need treatment. All right. Like I said, 95% resolve it themselves. All right. And then you have people that have acquired immunity through infection. All right. And so and basically here is that your body mounted the, appropriate level of antibodies to fight the virus, and you don't require any treatment. And then here, this third column is immunity through vaccination. All right, which typically through here, you only have like one of the antibodies, but you still have protection. All right. So, you prefer to get it through vaccination than through infection, but either way, you have immunity. That's what matters at the end of the day. Now, here, far column, chronic hepatitis B, you have your antibodies a lot of times. Sometimes you can have here that it's a little bit different. I don't know why they have this chart like this, but sometimes you can have your surface antibody. But the main thing is this up here, the HBs AG. This is the antigen. This is basically like the active virus, all right, that has just persisted. So what happens is that these patients typically require treatment, usually indefinitely, all right? Or what you can do is based on the viral load and your liver enzymes, this is the ALT, is that you may not necessarily need to treat, but you need to recheck the viral load and your liver enzymes periodically, maybe every 3 to 6 months, just to make sure that your viral load doesn't spike to extremely high levels or your liver enzymes don't spike to extremely high levels, because at that point, then you would need treatment. All right. So that's hepatitis B. Now, hepatitis C, which I my practice outside of HIV, hepatitis C, I do a lot of this too. All right. And so, we mentioned hepatitis B is a leading cause of chronic liver disease, and so is hepatitis C. And I would say hepatitis C in my practice is way more prevalent. All right. Same thing, persistent infection with long-term viremia means you have viral loads that just persist and persist. All right. So a lot of times patients just, if you had a little fun when you were younger, no judgment, but this is how you usually acquire it, usually through injection or inhalational drug use. Or if you got a tattoo outside of a certified parlor, so did you get a tattoo on the street? Did you get a tattoo in prison? Um, kind of those kind of high risk social behaviors, then, like I said, you're at risk for hepatitis C. And your body, you may have had, you probably didn't think about it, but maybe you felt a little under the weather, but you didn't really have severe symptoms. But like I said, your immune system took care of it. Now, as you get older, there's a chance that as your immune system wears down, then you can start having more symptoms, such as you're feeling more tired. And typically is the symptoms and how you know, patients born between this region. And not just that, but even after will come and present and they're like, hey, I'm feeling a little more tired. Or, more severe cases, did you have a swelling in your abdomen, swelling in your legs? Did you notice that your eyes are turning a little yellow? You know, then that's when, the virus is probably become a little more prevalent and your immune system is weakening. But I will say that for most cases, patients, at least I see and my colleagues, I mean, it's usually men that's usually probably like 50s, 60s, even some early 70s that I tell them, it's like, hey, look, you've probably had this for maybe like 40, 45 years. All right. But you need to treat it. I mean, I've seen viral loads as high as the 10 millions. All right. But like I said, you want to treat this is because if you don't, you're at high risk for hepatocellular carcinoma, which is liver
Yeah.
cancer. All right. And typically this occurs in situations when patients have cirrhosis. So, the treatment for this is that, we have antiviral therapy. We call them direct acting agents or protease inhibitors, and that just works in the certain in the particular replication phase of the virus. These medications are a lot better than what they used to. When people were diagnosed, probably back in like the 90s, early 2000s, there were only really two medications out at that time and had questionable efficacy and with a lot of side effects. But I would say in the past 10 years, really made some headway and getting these people treated. And so, and I have another chart where I kind of explain a little more of that. This right here is just the natural history of it. Of most people, like I said, they have acute infection. You do have patients that, their immune system's able to fight it off. And then you don't require treatment. But if you have a persistent viremia or that viral load is just still present, and eventually as you age, it's going to continue to increase. And I mean, this happens over, say like 20 years here. And like I said, a lot of patients I've seen, they probably had about 30, 40 years. then that's when, like I said, you're at a higher risk for cirrhosis and end-stage liver disease and hepatocellular carcinoma. So it's typically how this works. We pretty much talked about, who should be screened. So if you ever injected drugs, person born between 1945 and 1965, if you've, Dr. Gary mentioned about the liver enzymes. So if you had some elevated liver enzymes, you probably need to be screened for hepatitis C. Those on hemodialysis, if you receive transfusions, um, and tattoos, if you didn't get them in a certified parlor, um, such and so forth. Now, this say table here outlines certain, I will say, social behaviors such as alcohol use, as well as if you have any concomitant infections. And these are basically factors that can be associated with cirrhosis if you also have hepatitis C. So if you're a big time drinker, or those who have high alcohol use or heavy alcohol use, and you have hepatitis C, then your risk for cirrhosis is significantly elevated. If you're co-infected with HIV or hepatitis B, significantly higher. Fortunately, more birthdays that you have, just higher risk for cirrhosis with hepatitis C is untreated. And then the duration is what we talked about. Now, when people have cirrhosis, these patients had it probably at least 25 or 30 years. You're not going to see cirrhosis, say, if you only have for 10 years. All right. So this is a very indolent virus, but like I said, it needs to be treated. All right. And then, like I said, this, there's a couple of pictures here. This is just the actual liver cell and then the virus and how it pretty much infects the liver cell and how these treatments that we have now target certain, steps in that replication phase and just how these medications work. So, and it mainly works through targeting the enzymes that cleave the proteins where the virus repackages and gets released from the cells. So that's where a lot of these medications work now. And to getting to the point where, as you see here, where the medication we had at the beginning, you had interferon and ribavirin, and a lot of times patients didn't tolerate these at all, and they're questionable efficacy and a lot of side effects. But then now, as we've moved, and I'll say particularly in the past 10 years, which is why I highlighted, from 2014 on, a lot of medications that we have, these meds work very well. I've seen them on commercials. I think Maverick's probably the latest one I've seen on the commercials. Maverick, Epclusa, Harvoni. I'm trying to think if there's another one that I'm missing, but typically Maverick and Epclusa are your main ones. All right, and these medications here, you take them daily. All right, Maverick's usually 3 pills once a day. Epclusa's 1 pill once a day, and you take Epclusa could be between 8 and 12 weeks. Or no, yeah, actually Maverick's 8 to 12 weeks, sorry. And then Epclusa is usually 12 weeks. But basically to say is that you don't have to be on these medications for 2 or 3 months. We get a viral load 3 months after you take that last dose. And then if your viral load's undetectable, you are cured. And as long as you don't re-engage in any of those activities, those high-risk activities where you could be reinfected, then you're good. You're cured and you move on with your life.
You've come a long way.
Yep. So, and then here's other treatment that for patients that have liver cancer due to hepatitis C, this is type of procedure that interventional radiology does. It's called a TACE procedure. And what they do is that it literally, here's your aorta and they get access to your hepatic arteries. So your arteries that lead to your liver. All right. And yeah, they have chemotherapy that they literally inject in the tumors. And so this could sometimes be part of the treatment as well if, unfortunately, their disease is advanced. And so you, like I said, have to do this in combination with treating the hepatitis C. All right, so next we're getting to human papillomavirus, HPV. All right, these are epithelial tumors of the skin and mucous membranes. All right, and you usually acquire this through close contact within families or in school or sexual contact, so genital warts. All right, and then you have so many types of HPV, and so certain types aren't as serious, where you just have like a wart, say if you've ever had a wart on your finger. All right, that wart is different than say a wart that you have, in your genital region. All right. And just like with chicken pox and shingles, it's a latent infection. All right. So you're probably infected, and then any type of stress, then it becomes alive again. And then depending on the severity of it, um, if untreated, can lead to the cervical cancers. And this is where I'm getting to the vaccines. Or in some cases you have head and neck cancer. So, this chart here pretty much, outlines when you should be screened. All right. For cervical cancer. And so you have all these different organizations, um, the United States Preventative Services Task Force, American Cancer Society, American College of Obstetrics and Gynecology. So they all put out the recommendations on certain things, and it's like, hey, you should begin for women in here, uh, begin PAPS age 21, and then how often? Typically every 3 years. And then after you've had so many negative PAPs, then you either don't really need to be screened anymore, or if you had it, then and you've been treated, say you need it in about 5 years. All right. Um, and then you could discontinue screening at 65. And then of course screening guidelines are different if you've actually had any type of what they, if you can see here, CIN, which is like cervical intraepithelial neoplasia. So if you had any type of local cancer, then screening guidelines are different. All right. What I really want to get into, and this is the really kind of what I want to emphasize, is the vaccination. Okay. And so we have two vaccines that are out, both approved by the FDA for the prevention of cervical cancer. All right, and you have the Gardasil and the Cervarix. All right, the Gardasil is the more popular one, I will say, is because it's quadrivalent. So quad is 4, all right, because it covers 4 serotypes, 6, 11, 16, and 18. All right, and these are the more serious types that do cause cervical cancer. So typically most people, you get the Gardasil. All right, you can get the Cervarix if you want, but most people get the Gardasil. All right. And even if you were, say, suffered infection with one of the types, the vaccine will still cover against all the other ones. All right. Um, there's already been a significant impact already seen in the US and worldwide. And then even in Australia, apparently it's reported that there was like a 93% reduction in incidence of genital warts among women younger than 21. So which significantly decreases your risk of cervical cancer. Gardasil has also been approved for males as well. Now, obviously, males don't have to worry about cervical cancer, but I just wanted to throw this in here because it's also available for them as well. So the Advisory College of Immunization Practices, the ACIP, all right, these are recommendations that you receive either Gardasil or Cervarix for basic females between 11 and 12, and you can get it as early as 9. And then if you don't receive the vaccination during that time period, you can receive a catch-up pretty much between 13 and 26. All right. And then kind of what I mentioned, the Gardasil is only indicated for males, kind of same thing. And then, like I said, I wanted to throw this in here, even though it's not cervical cancer, but mainly because we talked about HIV here, that men having sex with men is also indicated for them, those age 22 to 26 who are HIV positive. And then the vaccination schedule. So typically you receive 2 doses of the vaccine starting the series before your 15th birthday, and the second dose should be given 6 to 12 months after the first dose. All right. And yeah, I kind of threw all the rest of the stuff on here, but the main, points are these first two. All right, again to Epstein-Barr virus. So you usually get EBV when you're younger, or usually when you're a teenager, you know, you kind of get having your first boyfriend, girlfriend. Usually that's when it's usually acquired, or if you just share some food or any other intimate contact, it spreads to the B cells or B lymphocytes. All right, and the B lymphocytes are another component of the immune system. All right, and it usually establishes latency or latent infection in those cells. All right, so the acute infection, which is called infectious mononucleosis or mono, that's what they call it. Like I said, it establishes a latent infection. So usually once you have it, it's going to be there for the rest of your life. Now, the key is that you don't want this virus to reactivate. And this virus typically reactivates in the setting of any type of immunosuppression or when your immune system is low. So we talked about HIV. Now, typically with reactivation EBV, at least for the few cases I've seen, is typically in post-transplant patients. And it's because they're on the immunosuppressive medications to prevent rejection of that transplanted organ. So, how does EBV cause cancer? All right. Once again, it's typically a lymphoma. All right. So, widespread lymphoma or brain lymphoma, it can cause kind of like a Hodgkin's lymphoma. All right. And then some other cases, like if you had a head and neck cancer, so nasopharyngeal. So, like I said, this is kind of in the nares or kind of in the throat cancer. Few cases may be gastric cancer. I don't see this much. Burkitt's lymphoma. This is typically seen outside of the U.S., more so in Africa. And these tumors are very large, very aggressive. But in the U.S., and like I said, we typically see this post-transplant patients, which we call post-transplant lymphoproliferative disorder. So uncontrolled proliferation of these B cells that are infected with EBV. Like I say, going back to the fact that cancer is basically dysregulated production of immature cells. All right. And where you have these enlarged lymph nodes, pretty much could be all over your body. All right. And then the side of presentation, at least for those who are post-transplant, usually whatever organ that was transplanted is usually the organ that's affected. And there's just some pictures here. This is a CAT scan. I like showing pictures, kind of spice it up a little bit. And so way you look at it is that here at where I got my arrow here, this is like the abdomen, and then right here is the back. And then you see this other arrow here. You have lymph nodes all throughout your abdomen, and these large areas are your lymph nodes. All right, so this is how it looks under a CAT scan image. And really for monitoring therapy, a lot of times you have to reduce your immunosuppression. This medication here that I kind of alluded to earlier called rituximab. All right. And so this medication is a monoclonal antibody. So MAB, monoclonal antibody, directed at one of the antigens in the B cells. All right. Now here's the problem. Now it attacks the B cells that have been infected, but it also attacks B cells that haven't been infected. So what happens is that your B cells are wiped out for on average about 8 months. And so it's kind of really weird where one step here you say reduce your immunosuppression, but then here's another medication where it takes care of the infected B cells, but it can actually suppress your immune system. So if you ever come across this medication, if you ever hear it, then this is what it does. All right. And then these are just some other cancers that you can get from EBV and another type of lymphoma, which is lymphomatoid granulomatosis. Another one kind of mentioned earlier with HHV8, which is primary fusion lymphoma. This is fluid associated with lymphoma outside of your lungs. All right. Then we're going to kind of wrap up here. This is the last one, human T lymphotropic virus. It's a retrovirus similar to HIV, so it pretty much works the same way. Usually acquired through any type of sexual contact or mother to the child, which maybe the mother was affected and happened to pass it to the child through pregnancy, injection, drug use, blood transfusion. Now, like I said, I want to bring this up because this can cause a cancer. Don't really have to worry about this much so in the U.S., but if you've had some travel, or those maybe from the Caribbean or Africa, Japan, Australia, and like I said, haven't seen this too much, but those that have had HLV, usually they're from the Caribbean. All right. And the cancer that it causes here is an adult T cell lymphoma, and this is like an aggressive high-grade lymphoma. And these two pictures on the right is just how it presents these large violaceous plaques. All right, and this is just describing. It works just like HIV. So that's why I just shared this picture here. Starts out as an RNA, DNA, and then turns back into RNA, and it incorporates in the host genome, where then it continues on and then makes the proteins, packages up into a virus, and then keeps going and infecting other cells. Show these charts here, and this is just the prevalence. All right, so like I said, these, the prevalence is higher where I mentioned Jamaica. So this chart I found here from Jamaican food handlers. Okinawa, this is out in Japan. So basically, like I say here, the prevalence is higher in these areas. And then if you look here with US blood donors, very, very, very low prevalence. All right. But like I said, this virus can cause cancer. So this is why I just wanted to mention it. And here, this just says, hey, if you have the adult T-cell lymphoma, which is a very aggressive cancer, and there are different types. If you have, acute, regular lymphoma, smoldering means it's more of a chronic type of cancer. Not quite as chronic as what they call chronic type, but it's a slower progressive, say, type. But these are the survival patterns. So like I said, I just want to throw those in here. If we happen to have someone here that, might have been affected by this, or, mainly for education purposes. So this is my last slide.
Well,
So
Dr. Wooten, that was Viral Oncology 101, 202, and 303. Very, very complete in your presentation. It was when early in my career, I would see this HTLV1 manifest as lymphoma in the Vietnam casualty
Oh,
got
wow.
transfused in Okinawa.
Wow.
So I saw a couple of those. They were rare, and I didn't see them later in my career. Just from the standpoint of emphasizing the prevention aspect here, we do
Mm-hmm.
have vaccines for hepatitis A, hepatitis B,
Mm-hmm.
HPV is
Right.
really, really important. In fact, I think it's a pie in the sky aspirational goal that if everybody got HPV vaccinated, male and female, we'd kind of eradicate cervical cancer.
Right.
Uh,
Absolutely.
and I think that's what Australia is trying to do. Uh,
Mm-hmm.
so that is a completely unnecessary cancer to get if we follow the vaccine recommendations.
Absolutely.
And we talked about the chickenpox vaccine, but that's not necessarily so much the oncogene.
Right.
So I think this is a really good and complete thing. I just want to make sure that we emphasize that there are vaccines out there that are available to you that you should receive. Even though we have a vaccine for HPV that causes cervical cancer, if you haven't received that, then please get the screening that Dr. Wooten recommended there in his one slide. But I think that's a real complete thing, and hopefully people will get a benefit from it. But we very much appreciate the time that you put into this and
Yeah.
the completeness of your presentation.
Yeah. Thank you
Uh,
very much.
Thank you, Dr. Wooten. And next month, we're going to be talking about women's sexual health, the questions you have but are afraid to ask. And Dr. Laura Wang of the Prisma Gynecology Center will be our presenter for that. And as is my usual pattern, I leave with a quote, and this is from the late and great Maya Angelou. My wish is that you continue to be who and how you are, to astonish the world with your acts of kindness. So for Dr. Wooten, this is Jeff Jagger, and we're signing out, and we'll see you
Oh,
next
I
month.
just I was going to add one more thing actually,
Thank you.
and just for education for the crowd. So there's a vaccination called Twinrix actually, and we can get hepatitis A and B together. And so
Good.
I wanted to throw that in there so you can kind of accomplish two usually together. So
And,
that is out there.
and we're
Um,
still working on HIV.
Yeah, that yeah, definitely ongoing work there. And then, there was even talk about vaccine for hepatitis C. That's definitely still in the works too. So, but I just wanted to throw that thing out there with Hep A and Hep B vaccine together. So,
Great. Thank you, Dr. Wooten.
all right, thank you.
See you, everybody.
Yep. All right.